Hi, everybody. I'm Dr. Carmen Puliafito, and I'm here today with Dr. Mark Barakat of Arizona Retina Consultants. He's director of the Retinal Research Institute that they've created at that practice, and also is a clinical assistant professor at the University of Arizona School of Medicine in Phoenix. Mark, welcome to Retina Synthesis.
Well, thank you so much for having me.
We were very impressed with your talk on the Kingfisher trial, which is a brolucizumab diabetic macular edema trial. Can you tell us a little bit about the study design and why the study was performed?
No, absolutely, great question. So, as you know, we're fortunate to have several trials comparing different agents in exudative diseases such as DME. Many of these trials, however, have different treatment algorithms, different intervals between arms, and that limits the conclusions that we can draw from a truly matched and head-to-head comparison. And many of these trials also involve extension, but by definition, beyond the 4-week interval. And so while many of these patients in DME do well with extension, as you know, in our clinic, some don't, and they have a high treatment frequency, high burden. And so there's definitely a knowledge gap, and this trial was designed to assess and help with that knowledge gap. So the trial design for Kingfisher was intentionally designed to be relatively straightforward. It's 570 patients that were randomized in a 2-to-1 fashion to receive brolucizumab 6 milligrams every 4 weeks versus aflibercept 2 milligrams every 4 weeks, head-to-head, 1 year long. And that was essentially it. The inclusion and exclusion criteria were also a little bit more liberal as well. Also in an attempt to mimic a little bit more closely the clinical conditions that we see in every day. So patients with a poor systemic control were allowed, with an A1C up to 12. Patients with low risk PDR were allowed. Patients with blood pressure up to 180 over 100 was allowed. And frankly, also previously treated patients were allowed. So patients that had anti-VEGF treatments in the past were allowed with a 3-month washout. So this was really designed to kind of ask those questions of a truly head-to-head comparison.
What were the central corneal, thickness measurements in these eyes and visual acuities?
Right. So they were well balanced. So the central subfield thickness was 511 in the aflibercept arm, 514 in the brolucizumab arm, which was thicker than in the Kingfisher and Kestrel trials. And the BCVA was approximately 61 letters in both arms.
Mm-hmm. So what was the study sponsor hoping to find out? What was their ideal result from the point of view of the sponsor, do you think?
I think it meant to address several questions. One, the safety, of course, especially with brolucizumab, with the rates of intraocular inflammation and repetitive usage, especially monthly in a population that might need it, is it safe? And secondly, how well does it perform in patients that are chronically treated, or the previously treated patient population? Might it perform somewhat better than aflibercept? We really don't know if we only have trials that have naive eyes. So that was, I think, the main goal here. I think perhaps initially the hope was also to help with the label. But I think since then, other information has come apparent, and I'm not sure that they will pursue any changes in label as a result of this trial.
So what were the study results?
So the primary objective was whether or not it was non-inferior in terms of changes in visual acuity at week 52, and it met non-inferiority. So patients with brolucizumab at week 52 gained approximately 12 letters, and patients with aflibercept gained about 11 letters. It almost, but didn't meet superiority in this. Secondary endpoints were anatomic, of course. And so in terms of central subfield thickness, at every visit, frankly, the brolucizumab arm outperformed the aflibercept arm, at least numerically. And at week 52, it met statistical superiority by a delta of about 41 microns. However you want to slice it, if you want to look at maculas that are essentially normalized with a central subfield thickness of less than 280 microns, if you look at the proportion of patients in each arm. In the aflibercept arm, it was approximately 41 or 42%. In the brolucizumab arm, it was about 66%. If you want to look at maculas that just had no intraretinal fluid for subretinal fluid, the proportion was also higher in favor of the brolucizumab arm, 42% over 22%. And in terms of the speed to dryness, now we can ask ourselves whether or not this has a huge impact, but the median was achieved. So 50% of patients achieved the IRF and SRF-free macula by week 52 in the brolucizumab arm. Didn't really achieve it during the trial, I mean, the aflibercept arm. So if you want to compare apples to apples, if you want to look at when 20% of patients achieved in IRF and SRF-free macula, so that happened at roughly week 20 for brolucizumab and week 40 for aflibercept. So it is also somewhat faster in achieving a dry macula. And of course, I looked at DRSS improvements, two-step improvements, and these were non-inferior with approximately 40% in each arm achieving a two-step improvement at week 52. So if you were to summarize it, you could say that it is non-inferior in terms of visual acuity changes, and it is superior in the anatomic benefits that you see with drying agents.
Of course, we're not treating patients 12 every month with diabetic macular edema in our current treatment paradigm. What's your treatment paradigm for treating diabetic macular edema?
Oh, that's a great question. You know, of course, you start out with an anti-VEGF, and unfortunately, I'm forced to admit that a lot of this is guided by insurance reasons. If you take insurance out of the mix, I think aflibercept is certainly the market leader in terms after protocol TE. What they have shown to us in terms of the drying ability and in terms of the vision improvement. I tend to start out with perhaps monthly. I have a very quick willingness to either stretch, treat and extend perhaps, or even go PRN. The fact of the matter is that with diabetic retinopathy, diabetic macular edema, it is such a variable, complex disease process. There's no one box fits all. You know, there's no one approach that fits all, and especially if you can also throw steroids into the mix. So it's good to have as many different options as possible.
And the brolucizumab had really no serious adverse safety signals in the study, correct?
You know, it's great that you mentioned that because, you know, of course, with brolucizumab, we worry about intraocular inflammation, and they did have intraocular inflammation at 4% in the brolucizumab arm, 2.9% in the aflibercept arm. They did have, you know, cases of vasculitis. They had 3 patients with vasculitis, so you know, 0.9%, versus 0.5 in the aflibercept arm. But in terms of visual acuity, as you know, they did really well, and most of these cases were mild to moderate and resolved without sequela. In terms of retinal vascular occlusions, one thing that we also worry about, they only had 1 case in the brolucizumab arm, and that was not associated with intraocular inflammation. I have to be honest, it's a little bit of a mystery why in the diabetic population we enjoy such a better safety profile than what we have seen in the macular degeneration population. But you're right, you know, it does look like it's better, and it's borne out in the kite and kestrel as well.
Yeah, it's unfortunate the safety information about retinal vasculitis in the macular degeneration eyes got attention right away. So
no, I agree.
Do you think the sponsor is going to extend labeling this to diabetes or diabetic retinopathy or not?
The sense I get is that they're very hesitant. So,
but it does show that brolucizumab is a tremendous drying agent, and drying the retina is good in general.
No, absolutely. I mean, I think most trials across the board, you can see brolucizumab is a fantastic drying agent. And if you look back in post-hoc analysis in terms of variability, in terms of central subfield thickness, in terms of the presence of intraretinal fluid, stability is really key. And in my mind, the best way to achieve stability is to keep the retina dry, right? So I think a lot of the trials that are currently ongoing and that have yielded results recently, our tolerance for some of the fluid has actually increased. So I wonder whether this is us advancing or whether this is us just looking at from a different lens, right? Time will tell.
Yeah, you formulated that in a very good way. So, Mark, thanks a lot for your time today, talking about Kingfisher and brolucizumab and aflibercept in the treatment of diabetic macular edema. An interesting clinical trial. We don't know how the information is going to be used. We'll see. Thanks for coming on Retina Synthesis.
Thanks so much for having me.